this is live, and I am just starting that now, so I missed the opening remarks, but my apologies, but this will be saved onto our CTDSS YouTube channel for public consumption, and it should be live.
You mean my comments were not saved for posterity, Brad?
Mentally, I took them in, so I'll go back and do my best impersonation of you at the end. Okay.
Got it.
All right, Carson, I'll pass it over to you, and thank you.
Great. So I think I'm actually gonna take it for a few minutes from here. Thank you, Commissioner, for the overview. We're going to spend the rest of our time today in two areas. So the first is just grounding us in a little bit more detail around why we're here and where DSS has been so far on developing a maternity bundle payment program. And then we want to spend the rest of the conversation looking at a health equity framework that we can use to ensure that every step of the way through this maternity bundled payment program, and even beyond this program for use in other DSS program development and updates, that we have a framework to ground ourselves in health equity, and that we can keep coming back to making sure that all of the design elements of the program meet or exceed our health equity goals and expectations. So let's go to the next slide, and I will we'll pause at specific moments to take comments and collect feedback. Though just want to reiterate the Commissioner's message that similar to when we had a few public meetings on this topic last year, wanted to keep the dialogue very open and honest and fluid through this process. So chime in the chat with questions or comments. We'll pause for discussion at certain points, but this isn't intended to be limited to just these specific forums. If you have thoughts or questions or ideas between meetings of this group, feel free to email any of us on the DSS or the Faulkner team, and we will ensure that those comments and feedback and ideas are heard and incorporated. So this slide is just a reminder of why we're here and how we are going to design the program. So as the Commissioner highlighted, our intent is very much to address racial disparities in maternal health and in birth outcomes, to reduce the incidence of unnecessary C-sections and early elective births, to support parity between OBs and midwives, and importantly, to create access to doula services, community health workers, and breastfeeding support for our members. To the extent that there are opportunities to align with the work that the state employee health plan is already doing in maternity bundled payments, want to keep that on our radar through this design process. To the extent that we can keep the implementation neutral, cost neutral to DSS, and ultimately save DSS money while simultaneously improving maternal and newborn outcomes. That is sort of a fundamental premise of any value-based payment program. And also want to make sure we consider the impact of the timing of enrollment in limited benefits on maternal health and birth outcomes. To do this, the principles of design include aligning with the DSS goals, as we just described, ensuring that we're using evidence-based practices and best practices for designing the program, following the health equity plan that we will talk about in the second part of this meeting, ensuring that we hear and incorporate stakeholder feedback in a meaningful way into the program design, and to keep it simple wherever possible. And so these goals and principles are reflected in the work that DSS has completed to date, that we can talk about on the next slide, please. In 2 slides, sorry. So just as a reminder, as the commissioner highlighted, a core reason for why we're doing this work and why we're doing this urgently is that in some cases, the key outcome measures for maternal and child health are worsening since the pandemic. NICU utilization has gone up, adverse maternal outcome rates have gone up, and C-section rates and NAS rates have stayed flat. Whereas, if we were doing this in an ideal world, those would be coming down. So in order to address those key measures, there's urgency to act, and it's compounded by the racial disparities that we see among those, among each of those metrics. So if you see in the chart at the bottom, in general, the rates for Black or African American members are much higher than the overall rate, same for those who identify as multiple race. We'll have access to this information afterwards to keep, if you want to look at the detail. So on the next slide, we can just ground ourselves in the summary of where DSS left off with stakeholder input on the high-level design of the maternity bundle program from our 2021 working sessions. So for the maternity bundled payment, we said that the episode definition should be a comprehensive bundle where the payment and the program covers all phases of maternal health, prenatal, labor and delivery, and postpartum care. That all OB and midwife practices in Connecticut's Medicaid program, as well as family medicine providers who provide OB services, would be able to participate in the bundled program. That we acknowledge that newborn care it is very important and could and should be part of the bundle. It's likely that we would launch the bundle without including newborn care on day one and phase in newborn care over time. So that's an example of something that if we've made enough progress this year on that, we could revisit that decision. The population included in the program would be all Medicaid births, with a handful of exceptions for administrative reasons. So for example, an administrative reason would be if someone loses eligibility and comes back on, or moves out of state or something during the course of the bundle, we would define specific administrative reasons that they would be not included. We would also look at ways to define specific high cost episodes that might be excluded from the bundle in order to protect providers. And various programs throughout the country create clinical risk exclusions differently. The DSS principle would be to maximally limit those exclusions so that key diagnoses of interest that drive the outcomes that we saw on the last slide are not categorically excluded. And substance use is sort of a great example where we want to make sure that members who experience substance use are included and experience the value of this program. When we get to future sessions, we can describe the services included in great detail, though in general, what we came up with was that in order to ensure that the payment model has both a prospective payment component and a retrospective component, that we would look at all of the services within maternal child health and group them into whether they're services that could be paid upfront for the OBs and midwives and family providers on a per member per month basis that would give providers some cash flow to be able to invest in the program. And then also look at services that are important to driving the overall program performance, but that might not necessarily be provided directly by the OB or midwife that would be part of the bundle, but included sort of, we call it a retrospective reconciliation, which just means comparing what the budget for the bundle should be to what it actually was, and figuring out the difference between those two. We also identified a handful of services that could be excluded to make sure that that those services are still provided to the members and that they have access. So that's an area where we will go into great detail in a future public meeting like this to get your feedback on the specifics. Quality metrics is another area where we spent some time on last time, and we expect to go much deeper in this round. In the last round, we identified that there are 6 state employee health plan quality measures that would make sense to also apply in this program. The reason to think about using those measures is that providers who are participating in the state employee health plan and in Husky Health have some alignment in what they're getting measured on and how they're getting held accountable. But that, we know that commercial members do have differences from the Medicaid population, and that incorporating some of the Medicaid core bundled measures would also be important in order to ensure that we're driving towards the outcomes that this program should achieve. We got some great feedback last time about how important it was to stratify all measures by race and ethnicity while we're planning for the program, designing the program, and reporting out on and evaluating the program once it's up and running, and to make sure that we're providing that information to providers directly, and that quality measures are an area that are continuously evolving and learning from best practices. And so we would expect that the quality measures in year 1 wouldn't necessarily be the same quality measures in year 5, but that we would establish a process by which to update them annually. And so then on the next slide is just the quick reminder of the payment model concept that we talked about in the last session, in the last series of meetings. I mentioned this combination of trying to achieve a prospective payment paired with a retrospective reconciliation. In future working sessions of this group, we'll dive into more detail about what that means and what it could look like. When we calculate the overall time frame of services, looking at 40 weeks before birth as the start time for the episode, and at least 60 days postpartum, though there's pretty clear evidence and a plan that we would aim to do that for a much longer postpartum period. Again, can figure out the specifics of that through this process. In terms of pricing the bundle, we talked about a phased-in approach where when we first launched the program, it would be upside only, so providers would not be at risk for any losses. The next couple of years, looking at a model where providers would have a larger upside or savings potential and some limited risk exposure, and then by year 4 or beyond, that the savings and risk would be symmetrical, or it just means equal. Like if you could earn 50% shared savings, you would be at risk for 50% as well. We're looking at making sure that there's a blended price as the basis for at least a portion of the services that relate to vaginal deliveries versus C-sections, and incorporating that into the bundle. And that for the way the quality would tie into payment, it would be partially pay for reporting and partially pay for performance, where we would evolve more and more to pay for performance. over time. Excuse me. So let me just stop there and acknowledge that that was a lot of information and a lot of, in some ways, wonky detail about how a payment model can and should be created. And so our expectation is not that everyone on this call sort of understood the details of every single aspect of that. However, we wanted to make sure that we grounded ourselves in the types of conversations that we're going to be having over the next several working sessions. So by the end of this process, we should all have a shared understanding of what these design components mean. And so on the next slide, just wanting to flag that if to echo the commissioner's opening remarks, we want to implement this program as soon as possible. However, we also want to get it right. And so acknowledging that there's going to be a balance and a healthy tension between those two components. Looking at the bottom bar of this page, that in looking towards late this year, early next year, launching the full bundled program. As stepping stones to get there, we're going to look at doula integration and trying to launch that as soon as possible, where we establish a pathway for support for doulas and doula organizations to start the partnership and capacity building needed in order to have the maternity bundle payment program succeed. And also want to look at the blended case rate payment as a way to, it's a foundational building block of the broader bundle. There, we're anticipating talking about the doula integration in more detail in our next working session, and the blended case payment in the following working session, and then diving into some of the details of the maternity bundle payment program and workshop each of the categories that I just talked through in the sessions throughout the summer. You'll note that that we flagged there's an open policy question about whether the blended case rate payment work that we launch prior to the full bundled payment program or launch it concurrent with bundled payment program. And that's, again, the dialogue we can have together on this journey. So I'm going to hand it over to Carson to talk through the health equity framework and get your input there. But let me just pause and see before we move on to the health equity agenda item, any initial feedback or questions folks wanted to offer here.
We'll just ask maybe to use the raise the hand function if possible to help us if there are any, just given there's so many folks, make sure we don't miss anyone.
And also, re-emphasizing that consider this an open dialogue. I think on the calendar invites, you should have my email and Carson's email and Tiffany's email, as well as the DSS emails. And if not, we'll make sure that you get that after this session. So if you have questions or ideas or comments, we'll hear them at any time.
I think I saw Mark raise his hand, not on Zoom, but just actually in real life. Use the Zoom one, it'll be easier, but I'll help. And I'm sure between Carson, myself, and others, we'll pick it up. And I was just, before you say, I think, Mark, I just wanted to say that for the DSS side, Mata Williams and I are really the kind of co-leads working together very closely on this. So if there's questions that DSS needs to be involved in, will be involved as well as the Faulkner team. So Mark, let me pass it over to you.
Thanks a lot, Brett. So presentation is very clear on the topic of the blended case rate. There was one thing I wanted to flag because it wasn't really it didn't really surface during the high-level design phase conducted a year ago, which is that the savings proposition here, I think, is that moms have better outcomes, and we avoid avoidable complications through better care. And the hybrid payment model doesn't seem to take into consideration that there's significant differences in price between hospitals based on the Medicaid rates. For example, a birth at John Dempsey Hospital is sort of the base rate for John Dempsey Hospital on which a birth is based. This is not necessarily exactly how much is paid as over $12,000, whereas at another hospital, say Bridgeport, it's a couple of $1,000s less. So there's a reason that those prices vary. It's not negotiated price differences. These are differences based on the expenses of, say, wage differences and the role that hospitals play in professional education. And so I would just flag that if that's not taken into consideration, you could lead to a substantial flow of deliveries from hospitals that are legitimately priced at a point that puts them at a disadvantage in a hybrid bundle.
Thank you, Mark. And I realize the words aren't on the page this way, but the expectation is that when we're talking about the blended case rate payment, it's specific to the professional fees versus the hospital side, certainly as a building block for this program. So we can and should definitely look at that in more detail, but that's the starting point.
Terrific. Just wanted to flag it for the subgroup. Thanks.
Karen Siegel, I see you have your hand up. Please jump right in and let us know your question or comment.
I apologize if I missed this earlier, but it wasn't clear to me where in this process there would be a discussion of the specific quality metrics being considered and how those are tied to payment. I think that's an area where we could hear some really interesting feedback from the doulas and CHWs in the room. And I just wanted to make sure that was part of the plan for stakeholder engagement.
100%. And I don't know if when we get to the next step slide, I think that's outlined for this summer conversation. I can't remember exactly which month. But.
August. Yeah. Yep. That looks like it'll be in our, it's right now it's slated for the August meeting.
Yeah. So I think, we could shift it as needed, but the August would be what are the quality measures that we should consider? And then when we think about tying quality measures to payment, it would look at, I think we have payment methodology is the meeting following that. So in September, so we'll talk about both of those, the aspects of your question, the metrics themselves and how they relate to payment separately.
Great. I did see one question that was clarified in the chat, but probably would be helpful for everybody. We will be sharing the presentation with the group. So as Angela mentioned, we know it's a lot to absorb in a quick meeting. So you'll have the opportunity to do that, and please reach out to any of us with any follow-up questions. I don't see anything else. So in the interest of time, I think we can move on to talk a little bit about the next portion. And that's really to talk about the consideration of health equity, which is really promoting health equity is a central component for the work that DSS is doing. And as part of that, the team decided it really made sense to create a framework in the form of a template, actually, that could be applied certainly to this project, the maternity bundle project, but with the intent that it could be used in future projects as well when there are new programs being launched or updates being made to programs in the future. And it's really aiming to help the DSS to really intentionally apply that equity lens at each program stage of development. So starting with initiation, we have a section that really looks at the overall, what are the goals, and then doing a deeper dive when we're in the design and implementation phases, making sure that the design really is inclusive of things that need to be considered. And then there's an evaluation section, which is really intended to be, once post-implementation, how is the program working? Is it working as intended, and are the goals as identified in the initiation and design phase really being met? And this is the maternity bundle project will be the first time that we'll put this into practice. So the intent here is we'll run quickly through what we have documented as the different parts of the equity tool, and also the questions that we've asked, and are really, really hoping that people will provide feedback about things that you might think are not captured that really need to be, or things that maybe aren't being captured in the right way.
Carson, I would just offer, as you walk through the next section, want to acknowledge that we do only have 13 minutes left of today's session, and this is a really important topic. So review and think about the content, but let's also just plan that the next time this group meets, we'll pick back up and start with this topic to make sure we do it justice.
Great. Yeah, absolutely. So I think actually that we can move to the next slide, which is looking at section 1 in some detail, to share what the questions are, how we've broken out the different areas, and what the questions are within each area that we've come up with to be able to collect the information necessary to keep the appropriate lens. The expectation is that for the first section, it would be completed once at the beginning of an overall project, and really should mostly be applicable to any of the pieces of design within that program, with the understanding that as you go through design, there's always things that come up that you hadn't considered, or that maybe you end up thinking you'll need to go in a different direction. So we always want to make sure that there's an opportunity that section 1, although completed once, really can be updated as new information is gleaned. And what we have documented here are the goals, the questions about the goals. So what does this program aim to achieve, and what are the problems that we're really looking to solve with this new program, or for updates to existing programs? And what are the explicit health equity goals for the program? And within that, in order to get to the answers there, we broke down into a couple of different sections, one being the intended populations for impact. So who are the targeted population or subpopulations, with some ideas about what to be thinking about when you think about who will be most impacted. It could be a neighborhood or region. It could be particular racial or ethnic groups or income groups, and consider whether the design will benefit different populations the same, less, more so. So will one population see a higher level of benefit than another? And if yes, why? And the consideration of whether or not that's appropriate. The second piece of the intended population section is about how is the design intended to improve the health outcomes. It's great to think that we have the right idea and to have a rationale for design, but it's really important to be documenting those reasons so that everybody has an understanding of what the intent is. And it's something that can be considered through design and implementation to ensure that those intended improvements are met. Next is community context, and looking at identifying the history and current reality of structural barriers that may negatively impact the affected communities. So thinking about who it is that you're doing this, that the program is intended to impact through looking at unequal social determinants of health and education, income, neighborhood characteristics, housing. The list is extensive. Also looking at what does the data tell us about the current context. So Angela previously showed a slide that gave us some of the data of where are we now. It's extremely important to understand that to help inform how design is being done, and also to make sure that there's a baseline to be able to benchmark against once you are in the implementation phase to identify whether the program design is providing the intended impacts. And then finally, this is a really important one. What are the potential barriers or challenges that may limit the ability of this program to achieve its intended outcomes? It's really important to not just think about what are we planning to do, but also consider what are some of the ways that we, or the issues that may come up. There may be resistance, there may be, we may be creating some unintended consequences. All of those things need to be considered, and also what specific design elements are going to be incorporated in order to mitigate the challenges. It's tough to be able to identify everything before you've really implemented a program, but the intent here is to have the folks who are working through the design really think about what might actually be outcomes that you aren't expecting. Next is community engagement, which is a lot about what this meeting and this group is about. It really is incredibly important to make sure that those who will be most affected by these issues will be involved in the conversation, and also to identify who's missing. So we would look to this group for, especially to say, are there people or populations that you feel like should be represented in these discussions who are not, and how can we reach out to those folks and engage them? And then the feedback loop, and this is really kind of in the post-implementation, is looking at what mechanism is in place to provide and receive timely feedback as issues arise. So again, looking to the community, the people who are impacted by the design, we need to know from them, is this design actually, are you experiencing it the way it was intended? And finally, there's the data analysis and measurement. So looking at how the data related to health disparities is collected for this program. It's great to identify that there's data needed, but you also need to make sure that you're able to collect that data. And if you're not already collecting it, what is the plan for being able to make sure you've got it documented? And then finally, can the measures be stratified by different groups? So race, ethnicity, language, disability, and other demographics. And again, looking at what are the barriers that may be in place that will be make it difficult to collect that data in a stratified way. And what are some ways that the group can address that? I think we'll jump to the next slide. I'm not sure we'll be able to get through the last section, but I think section 1 and 2 are really where we're focused right now. So important to be able to have this group get through that. So section 2 is, unlike section 1, it's expected that section 2 will be filled out for each design element. So for the maternity bundle project, we talked about the doula integration and about blended payment. So we would expect that these questions will be answered specific to each of those different design elements. Some of the answers may be the same, but some of them may differ. And so it's really important to make sure that you're doing this on in a way that is inclusive and holistic. And so again, we're looking at what are the goals of this section. And there's two pieces. One is about the proposal and one is about equity alignment. So when we look at the proposal, what is the design element under consideration? So for example, the doula integration. And what are the expected results and outcomes of the design element? So the question's really needing to get to what did we expect the impact of this design to be? And when we look at the equity alignment, the two questions here are, how does the proposed design element impact existing inequities? And how does the proposed design element align with the project's overall health equity goals? Really important to make sure that for each design element, we're looking back to that section 1 of what are the overall goals of this program to make sure that those overall goals are being met by the different design elements. Again, the community context here are about the barriers and challenges and being aware of what those might be and doing what we can to make sure we can mitigate those challenges as best as possible. Second is considering each impacted population and how the potential design could create barriers or unintended consequences. So for example, for the doula integration, geographic distribution of doula providers, could we be solving a problem in one area, but then actually creating a problem in another area? It's important to consider that when in the design phase to try and avoid the need to make changes down the road or create problems down the road. And then the other piece is what plan or strategies will be utilized to mitigate unintended consequences by the design. So again, how are we addressing that? And it's great to identify that there could be problems, but we also need to be responsible for addressing how we're going to address those problems. Community engagement, again, throughout this entire, each of the different sections here is exceptionally important. And so here looking at how is the community voice considered for the design element. So ensuring that the community members, especially those who are most impacted by the program, have been informed, meaningfully involved, and authentically represented. I definitely, in the intros, it was helpful to hear who everybody was. And it sounds like there are some members of the community. That's great. I think there's probably opportunity to maybe incorporate more folks if there's a way we can engage those people. And finally, the data analysis and measurements. Again, what measures will be used to assess effectiveness of the design, and what are the success indicators and progress benchmarks? And do these measures reflect the equity goals? It's really important to make sure that they do. So in asking these questions, it requires those folks who are working on the design to really consider how they can be sure to provide these measures. And then what methods will be used for data tracking, reporting, and the other, sorry, I got the chat in my way, communication of the metrics selected. So making sure that we're not just tracking them, but we're also sharing out the data with folks. And we're using that data to analyze whether or not the programs are effective. So sorry, I'm speeding through this. I'm not going to go into section 3 right now, but I am wondering if there's, just a minute of time that we can stop for it and see if there are any high level comments or questions. Just going through, I'm not seeing any quickly. Okay, as we've said multiple times, we definitely have the opportunity for people to chime in after the fact. So please don't be shy about doing that.
I think Bianca may have been unmuted. You want to weigh in, Bianca?
Thank you. I just want to say that I like that you say that it's important to bring more community members to the conversation. So I just want to say that. Thank you. Absolutely.
Yes. I think that's great, and certainly welcome suggestions, Bianca, either from you or from additional folks of additional ways we can reach out to people in the community to engage them.
And just acknowledging from the DSS standpoint, I think this is an area we've historically, it's never been easy, I think, always for us to engage with as many members as we'd like, and we just are interested in that. So very much welcome thoughts and input and assistance with doing a better job through this process.
Great.
Something that I want to recommend if we want to involve more community members is that we can provide interpretation so they can participate no matter if they don't speak English. So for me, that is very important. If we can provide live interpretation, so we don't have to lose time making the translations, but if we can have at the same time interpreters, so they can hear the conversation and they can share their opinion or adore the concerns.
That's a great suggestion, Bianca, for sure. And I see, I think Tanya, thank you, reaching out to the OBGYN offices is, I think that's a great suggestion as well. Knowing that we are right at time, I just want to do a really quick overview of the next steps. So we will incorporate feedback from today's discussion and anything that you send to us in the next period of time with questions or comments, we'll be sure to incorporate that as well. We are working on preparing the doula integration concept, so we'll bring that to the next meeting. But as Angela mentioned, the April meeting, we are going to revisit the equity tool. We'll go through the third section of that. but would really, really, really love to have feedback on thoughts around what questions we have posed there, and suggestions for either changes to those questions or additional things that haven't captured, that we have not yet captured, details that you think is important for us to keep in mind. And you'll get this deck. So you'll be able to see, this is a quick review for each of the months through October, what we're going to be focused on in each of our sessions. But we will send this deck out to the group to make sure that everybody has the opportunity to spend some time with it and get back to us with any questions. Really appreciate everybody's time. And I'm sorry, I think we're about a minute over. I don't know if any of the DSS folks want to just say any last minute thank yous or anything, but
yeah, no, just very much thank you. We know we continue to need feedback, and also if format of this meeting, if that would be another thing you're welcome to provide us feedback on to make it more useful for you. And I saw a question about making sure there's emails. We can include that in the follow-up with the deck about who to contact for follow-up from the Faulkner and DSS team. So we will make sure to do that in our follow-up email communications to you. So thank you all. And again, myself and Fatmata Williams, who's also on, who's been helping with the chat, we're kind of our DSS point folks, along with Angela Carson and Tiffany from the Faulkner team. So thank you.
Thank you, everyone. This has been a great first meeting. I appreciate all the comments, and please don't hesitate. We will send our information so you can reach out to us. Thank you so much.
Thank you.
thank you all.
Bye-bye, everyone.
Bye-bye.
Thank you.